All right, good morning, everyone, and thank you for tuning in to Health Talk this morning. I'm Dr. Victor Politi. I'm the President and CEO of New Health, Nassau University Medical Center. As healthcare in America is changing, New Health is part of that change. So this half-hour program will provide you with some essential information about our services and facilities that provide top-quality care that fits into your lifestyle. So New Health roots go deep into Long Island history. What began in 1935 as a 200-bed general hospital has now become a unique health organization with multiple centers of care and a commitment to deliver excellent essential care to everyone at every stage of life. You already know us at Nassau University Medical Center as the premier Level 1 trauma center, but we have so much more to offer the community, including a full-service center of care for Nassau University Medical Center, the A. Holly Patterson Nursing Home, the New Health Family Health Care Centers, and other services that we provide to our community. Our improvements are making us a leading provider of primary and tertiary care services that rival the best in the country. So today we're very, very pleased to have with us our neurosurgical, our chairman of our neurosurgical division, a physician who is well trained and really is providing us services in our hospital that we didn't have before. As a Level 1 trauma center and as a stroke designated receiving hospital, the ambulances are continuously bringing us really bad victims of car accidents and other types of traumas where they have really bad head injuries and brain swelling and other types of neurosurgical problems. And we have now a neurosurgeon on staff at NUMC in our Level 1 Trauma Center, and we actually have coverage 24 hours a day, 7 days a week to handle any type of neurologic emergency. Same thing with strokes. If someone has a stroke and they have a bleed or an intracerebral bleed and so sort of blood around the brain, again, the neurosurgeon is the person that takes care of those patients. So having this neurosurgical service available is really a great, great asset to the hospital. And in addition to the brain, they also handle the spinal traumas and the spinal injuries. Neurosurgeons are the best that can be. I mean, and we have one of the top neurosurgeons here. So I want to welcome Dr. Elizabeth Fontana to the program. And Dr. Fontana, why don't you start off and tell us a little bit about yourself, where you grew up, where you went to school, and things like that.
Sure, thank you. So I'm originally from Boston, and I went to college at Harvard in Cambridge. After that, I spent 1 year doing some research at the Brigham. I was actually in the medicine department. I was just sort of trying to figure out what I was going to do with my life. And once I decided to go to medical school, I went to Columbia Medical School in New York. And once I came to New York, I fell in love with New York. I stayed at Columbia for my neurosurgery residency. And then in 2013, I completed my residency. I went out to Seattle to the Swedish Medical Center out there for 1 year. I was doing mostly tumor research out there, although we covered, really it was quite a mix actually of both spine and tumor cases. And then I came back here.
Wow, so Columbia and Harvard. So you couldn't get into any good schools, I guess? You had
No.
To,
Exactly. All the good ones turned me down.
All the good ones. So
Yeah.
Harvard University. So you go to Harvard, which is, as we all know, is a great school, and then Columbia University, one of the premier, Ivy League colleges, and neurosurgery, which is one of the, I guess, top residencies. So I honestly say your credentials, your background, your training is really second to none here. And then we put that on top of your hands. We put that on top of your personality, your bedside manner, and how you come across the patients. And you really, really bring a lot to Nassau University Medical Center. And I'm so proud that you're that part of us. And I think that Nassau County, needs to know that someone like you is on staff at Nassau University Medical Center. So neurosurgery, what is neurosurgery? And I sort of botched it up in my introduction and sort of talking a little bit about it. But why don't you tell me about what exactly neurosurgery is?
Sure. So neurosurgery is really basically surgery of anything that involves what we would call the neuro axis. So generally speaking, that includes the brain, the entire spinal cord, and the peripheral nerves. Peripheral nerve surgery doesn't come up that often, although it does sometimes occur in the setting of trauma. Also, frequently there's sort of limited stuff that we can actually provide to people who have a severe peripheral nerve injury. Although technology has certainly gotten better with grafting in more recent years. spinal cord injuries and intracranial injuries we see all the time at Nassau, and but there's also quite a bit of a lot of other things that we haven't talked about. In neurosurgery, there has been really an expansion in the field of functional neurosurgery, really, and I would say the last 10 years, as imaging and computer technology have really sort of collided to enable just enormous amounts of data processing. What we've been able to do and the kinds of tools that we've really been able to utilize in the OR are just kind of mind-boggling nowadays. We have essentially something called Neuro Navigation, which is like basically a GPS for the brain, so we can figure out exactly where we are at any given time in the brain based on facial landmarks. And now the technology has really gotten to the point that that's true in the spine too. And it's getting sort of slicker every year. Every time I go to a meeting, there's new stuff. Functional imaging has really come a long way, and so it used to be that we had to do awake surgeries really to safely resect certain parts of the brain. Nowadays, functional imaging will help us to figure out where what we would call the eloquent cortex is, so sort of an important motor area. Can often be identified just using special types of MRI imaging, and that enables us to do the surgery on someone who asleep that we would normally have, a long time ago had to have done awake. There's all kinds of cool mapping that we can do in the OR. It's cool.
So, I mean, you make it sound so simple and, like every day. I mean, but, I'm a physician, and I've scrubbed in on a lot of neurosurgical cases, and it, to this day, amazes me that, and listeners, I know you guys aren't all doctors and nurses out there and paramedics, but let's just give you an idea that she actually removes the top of your head, and your brain is sticking out, and she actually goes into that brain. I mean, our brain, we're talking our brain, and actually goes in there and actually is able to remove a tumor, or is actually able to take a vessel that's bleeding and put a clip on it, or to fix something inside your brain. And then you're able to then put the top of your head back on, and with a short recovery period, you go home like nothing happened. It's just, it boggles the brain, the mind, that someone could actually do this and do it as well as you do it. I mean, it really is amazing. So, I mean, someone has a car accident, they have blood in the brain, you do these types of procedures. How well do they do? Do they do well after these types of things? Everybody gets always nervous. You have a bleed in the brain or a car accident with some blood around the brain and swelling.
Yeah, it's hard, it really is. There are certain things that are very predictable, and there are certain things that aren't. If someone has a clear bleed and not a lot of other injuries, oftentimes just removing that blood will be, a home run. They're completely sort of recovered from whatever deficits they had. They're able to move the side that they couldn't move before. They wake up, and that's incredibly gratifying. There is often a scenario where a patient has had some sort of traumatic brain injury and, concurrent with whatever their hemorrhage is and their other insult. And in that case, sometimes it's hard to predict, what kind of recovery they're going to make. And so, always we err on the side of caution and, try and give them the best chance that they will have for the best recovery.
Right. I mean, because it's amazing, today that you're able to do that. I know at Nassau University Medical Center, we have, after you do your magic, and we put them in, we have brand new ICUs, brand new intensive care units, surgical intensive care unit. After they finish with your operating room, they go to the post-anesthesia unit, and then they move into our intensive care unit. Yep. And so we just redid that whole place. It's really nice. It's beautiful. Yep. We have top, nurses, and, you have, of course, all you board-certified guys that are taking care of the patients. Yeah. And after recovery in the intensive care unit, we move you up to our rehab unit. And it's a world-renowned rehab, a nationally known rehab. U.S. News and World Reports, top 100. We have physical medicine rehab specialists. We have occupational specialists, physical therapy specialists in the hospital. That really is amazing. And it's so good that other hospitals in Nassau County send their patients to us. So that patients that have, problems in neighboring hospitals to Nassau University Medical Center, then transfer them over to us, and we give them that several weeks of intense physical therapy and physical medicine rehab to get them back on their feet, to get them home. So we do have all that to back up not only what the ambulances do to save their lives, not only what the ER guys do to save your life, and then to you, the operating room, but we do the whole continuum of care where they do get the physical medicine rehab. Matter of fact, even upstairs in I think it's the 6th floor where we have PM&R, they actually have a room that's like a house. Did you see it? It's like it's got a bedroom, it's got a kitchen.
They can practice their
activities
of daily living.
Right. They have like a Mr. Coffee machine and a washer and a dryer. So and not so much like even we talk about the trauma stuff, but people have regular strokes or have other issues, and we get them back on their feet that they can make a pot of coffee in the morning. They can do their own laundry or vacuum, and they even have like a little supermarket area, right, where they teach people how to lift the get food off of the shelves and an ATM machine. So the hospital really has a lot of really good things, and really one of the reasons that we have this radio show is just to get that word out to people, because they think of NUMC, the NUMC, NICMIC, whatever it was called, Meadowbrook Hospital, and they think it's like the old days where it was had a lot of different types of patients. And well, guess what? It's not the old hospital anymore. It really isn't. And not just in neurosurgery. I mean, in cardiology, just about every GI medicine, pulmonary medicine, and neurology, nephrology. We're really bringing in the top docs. We're bringing in top trained people that really have a heart and a great personality to deal with patients, and it means a lot to us, because we are a stroke center, which means that if someone's having a stroke in Nassau County, that we are the hospital that patient will be brought to, in addition to the trauma. And our docs in the emergency room, board-certified guys, are equipped with that clot-busting medicine to dissolve the clot. We call a stroke code, just like you have a trauma code, we call a stroke code. And you guys come down, the neurologist comes down. We clear the CAT scan, so that person gets brought in, and immediately it gets seen and gets brought to the CAT scan so they can see what's going on inside their brain. And then you guys come down, and we all move aside, and here they come, and and there comes the white jackets, and we let you guys in, and you just make those really life-saving decisions whether the guy needs to go right to the operating room or treated more conservatively. So I mean, and really that's what we're doing here, to not just showcase you as one of the great neurosurgeons, but to show what we have at our hospital, and that people in the communities want to, Levittown, Belmore, Massapequa, everywhere should know that this hospital is there. I mean, because we do have a large following of patients in the hospital, and they come back and they really like the care that they get. So with the spinal stuff, like the neck, spine, like back pain, everybody's got some degree of pain, especially when you start getting a little older and you're a little bit athletic. And, you just pull things, your knee, your back, and a lot of people have back pain. Do you guys see a lot of back pain, and do you work on patients with chronic back pain?
Yes. So it's probably the thing that I see the most of is really, degenerative spine disease, more often even than trauma. And, so people get disease in the cervical spine and in the lumbar spine. Most typically, the thoracic spine is generally spared and is a little more stable because you have your rib cage to sort of shore it up. We do the whole gamut of basic spine surgery there. So, the most common thing we probably do in the neck is anterior cervical discectomies and fusions, which is a very straightforward procedure used to treat disc disease in the cervical spine. And then, depending on the patient's needs or their imaging, a lot of different factors sort of will play into whether or not we decide to do something posteriorly, which is a surgery from the back of the neck. And then in the lumbar spine, people often present with herniated discs. They can present with something called spondylolisthesis, which is when one vertebral body is slipped forward onto another. That happens a lot in older people as their joints get more arthritic. And so we can do decompressions and fusions from, on any part of the spine you
Sure.
you need. We could operate from head to toe. I just wanted to add, though, to your comment about the rehab, that I have sent quite a number of patients, either from trauma or, just patients that oftentimes have come in even before we operated on them, somewhat debilitated and, needed a little bit of sort of tuning up and, strengthening of certain muscle groups and stuff. And, I've been very happy with the way that they've done. It's nice for me because I'm able to see them every day still while they're on the 5th floor. I think that they've been getting very good care. I always say that the hardest part is really the patients have to do all the work at the end of the day. I have the very easy job, to just fix the thing, and then and then they have to make the recovery. So that's really the hard part. And I think that the rehab at NUMC has been very effective.
So like back pain or lumbar pain.
Yeah.
So many, when I was an ER doc, I used to get so many patients with really, and they'll be fine for a long time, and then they'll sneeze the wrong way, or they'll lift something, or do something, and then their back goes out, and they have the sciatica and the radiculopathy, the pain down their leg, and they're really like 10 over 10 pain.
Yeah.
And they're in the ER, and they're squirming around, and I try to give them an IV and some pain medicine and try to help them out.
Yeah.
But, I try to tell them, listen, you can't live like this. You have to see, get some imaging studies.
Yeah.
So if someone has back pain, they have that, every once in a while, it's really debilitating, can't get out of bed, they treat themselves with Motrin, in a day or two they get better. What should they really do? Should they follow up with a neurosurgical person?
Sure. So conservative management for back pain has been looked at and compared to surgical outcomes. And for people with acute discs, first of all, just about 80% of them will actually get better eventually on their own. The reasons to really do surgery, the indications for surgery are if they have debilitating pain, so they can't get out of bed, they can't go to work, or if they have weakness. If they have an actual neurologic deficit, not just pain, that's really concerning, because once you start developing deficits, it's hard to sometimes get normal function back. So that's not something that you would want to let slide. That said, really, if you have back pain, it's very reasonable to get imaging, and an MRI is generally the most helpful form of imaging. And then oftentimes when I see patients, I'll recommend that they try, if they haven't already, if they'll try a regimen of Motrin. Sometimes we'll give them steroids. We always recommend physical therapy, and sometimes patients will want to try injections for an acute herniated disc. That can work. For more long-term back pain like stenosis, it's generally not a very effective method, but there are definitely certain presentations where it's quite appropriate and can be very helpful in getting someone through an acute period. And patients who have tried conservative measures for a month or two and they really don't feel like they're getting better, or if they come in and, like you were describing, with so much pain they can't even get out of bed, or they have a neurologic deficit, then we just take them to the OR. And the fact is that it's a very straightforward surgery, and often they feel immediately better and they go home, the next day. Wow. I can't wait to get out.
So, people say, okay, neurosurgeon, brain surgeon, what is she doing in your lower back? But you described it and you explained it, that it's all part of that neuroaxis, and it includes the brain and the spinal cord. And down in your spinal cord, all little nerves come off. Some of them aren't so little. And the lumbar spine, like you said, is not protected by the ribs or anything, so it's very exposed. And people are always lifting with their back, not with their knees. And, so we see a lot with cops and firemen and EMS guys, right? The nurses and the PCAs moving a lot of patients. A lot of people pull their backs because they don't know how to lift correctly, lifting up, lift with their legs and their knees, not bending over and lifting up, the baby, bending over and picking up the baby 400 times a day, puts a strain on your back. It hurts you.
It does.
So, so now you have these nerves that are coming out of that spinal column, and they go and they supply the muscles in your legs and the sensory things in your legs and stuff. And for whatever reason, that disc, there's a little cushion between all of the vertebrae, all of the bones in your spine, and for some reason, that little cushion slips a little bit or moves a little bit, or that area, that little hole, that nerve comes out, gets squished. It gets stenotic, it gets tight. So now what do you guys do to fix that? How do you fix that?
Well, again, it depends a little bit on the pathology, and there's really two major types of pathology people will start to develop what you're describing, which is stenosis around the nerve, that causes
like sciatica.
Yeah, sciatica is sort of the more common terminology, but radiculopathy is what we would technically call it.
Thank you, neurosurgeon.
So one very common way is if there's a herniated disc, and so there's a ligament at the back of the disc that protects the spinal canal from disc fragments from coming out, and really sort of helps to contain the disc material. That can tear, like any other ligament can tear, if there's too much strain on it. And when there's a tear in the ligament, then you can get a fragment of disc that can come out and basically extrude and push onto the nerve. The other way that you can develop a bad stenosis on the nerve is if is basically the way I would describe it, the way I describe it to the patients is it's kind of like arthritis of the spine. So over time, the joints can get larger, they can get a little bit, essentially arthritic. They can get water, fluid in the joints, and the ligaments themselves, both in the back and in the front, can hypertrophy. So they get thicker, and they really start to compress the nerves. And that, again, can cause a lot of chronic pain often in both legs, not just one leg. In both cases, what we do is we take the simple answer is we take pressure off of the nerve root. So we remove whatever it is that's causing the pressure. It's either the bone and the ligament, or it's the disc fragment itself.
So you actually go in there. So you do some MRIs, I guess.
Yeah.
And you'll take a good picture, and you'll see the nerve, and you'll see the bones, and you can see the nerve getting compressed or bulged,
yes, you definitely
right?
can, yeah.
And so you have sort of a map when you go in there and you make a small incision in the back, and you do what they call a microdiscectomy or something, right?
Yep.
And you go in there and you just take a little piece of
Yeah.
the bone or ligament out, and so now that little teeny nerve that's coming through the little hole in your spine can breathe again.
Correct.
And that pressure now, when that's taken off, you could feel your pain goes away, you get the strength back in your legs, or a little physical therapy up and running.
Yeah, usually people have immediate relief. So.
Yeah, my brother was a city fireman, New York City fireman, and he was injured. And when he fell, his packs, they wear the sky packs, hit him in the back and fractured one of his lumbar spine, like you were just talking about, and he lost all use of his legs.
Oh, wow.
So they took him to the hospital, and eventually, he started getting some, feeling back, and they rushed him to his hospital for special surgery in the city at the time. He was a city fireman. And they did emergency surgery on him, and that's what they did. They removed a piece of his spine, and he did miraculously. I mean, you could never tell. He's 100% from the neurosurgeons did such a great job. They removed that broken piece of the bone off his nerve, and he's 100% better yet. So so you guys really, people live with this lower back pain. People live with this debilitating types of illnesses, when all they need to do is call up NUMC. Call us up. Really, and it's so simple. We have a phone number here for NUMC, and you just give us a call, and we'll make an appointment to see, a neurosurgeon or orthopedic surgeon.
Yeah.
New Health is, just so you guys take a piece of paper out. Everybody ready? All you people with back pain, try to get up out of the chair and get over to the counter there. 516-486-6862. That's the Center for Care, and all you have to do is call that number. I'll read it again, 516-486-6862. So give them a call and say, listen, I have back pain. I'd like to make an appointment to see the neurosurgeon or the orthopedic surgeon. And they'll come to, you could see them, they'll make an appointment. It's that easy. Get examined. If it's appropriate, you guys will send the guy for an MRI or girl for an MRI, and go over the results with them. And there's no need for people to, look, Scott Toos is writing down the number right now. He's got all sorts of aches and pains, So so you do that, and you see you guys, and hopefully, maybe depending on what the illness is or injury, you could fix it, then people can run around like bicycle ride and play with your kids and do everything where in the past you couldn't.
Yeah.
Yeah. So so many amazing things, but lower back pain, I think, is really such a very, very common problem, most of them, like you said, 80%. Don't require surgery,
right.
So they may just need some rehab, some conservative treatment to get them up. So other than the backs, lower back pain, the cervical spine, giving those pains down your arms and in your neck, and strokes and bleeds and stuff. What else do neurosurgeons do? What else do you guys get involved in?
Well, we see a fair number of tumors.
Mm-hmm.
I have seen a fair number of them since I've gotten to NUMC, and a lot of those, the most common types of tumors are really metastatic tumors.
Mm-hmm.
They're coming from somewhere else other than the brain. In that case, oftentimes it depends on really what the cancer is, how much it's spread, how far advanced the disease is. But a lot of times we can do something. And when we can do something, we have a variety of tools for what we can do. The simplest and most straightforward thing for us is obviously to take the tumor out if it's in a location that's amenable to being resected. If it's a smaller tumor, or if there are more than, if there's a number of tumors, another option is that we can do radiation. And radiation, again, has, even within it, a few different tools. There's whole brain radiation, there's focused radiation, and there's like gamma knife, cyber knife, all these different terms that people have probably heard, but they each have a place in terms of managing intracranial metastases, and then of course primary brain tumors as well.
And and I don't want to keep saying this, but you came about a year ago almost, or 8 months?
Yeah.
And you right off the bat, you found tumors. You found brain tumors. I hear the stories. The neurologists tell me that the neurosurgeon did amazing surgery on this woman, and you've really saved so many lives in the short period of time that you're here, and you've really brought a lot of recognition to the hospital. And people don't know that, and I know you don't. You're just a doctor. I'm like, that's what I do. That's what we do. We find things, we fix them, and you're so modest with that. But I mean, I remember when you first got here, and within the first couple of weeks, the neurologist was saying, "Now that Dr. Fontana, wow, what a job she's doing. She already found like 3 tumors. She's resected a tumor that no one else would touch." And and these people have gone on to to live their lives to the extent that they can with the conditions, the cancers that they had.
Yeah.
But even in patients that can have cancer and they have some neurological lesion, and you remove it and they're able to get function back, they could live the next few years fully functioning rather than bedridden.
Yeah, and that's the goal. In some cases is really just to improve somebody's quality of life.
So I mean, there's just so many things going on at the hospital, and the neurosurgeons is just one big piece of it, and a huge piece of it, that you wouldn't expect to see at our facility. And we're doing a lot of other stuff. We're expanding the program for neurosurgery. I know you guys do a lot of teaching. You do a lot of teaching to the residents. You do a lot of teaching to the ER docs, to everybody that comes into the hospital, as well as the first responders, the paramedics and the EMS people that bring us patients. They love knowing that the patients that they work so hard to save are going to go to a facility that's going to continue that level of care for them. So, I mean, I just can't say enough, and I just want to, wrap it up and just, give you a few seconds to say anything before we end the show.
No, I mean, I have assembled in the last, I guess, 8 months, 6 to 8 months, a team. I have a wonderful administrative assistant, Beatrice, who will help you get your appointment in a very quick period of time. I have a PA, Christine Ficaris, and a nurse practitioner, Perry Intal, and there are a number of residents that have been very helpful. So we are sort of developing a little team, and I think we work well together, and we're trying to give everyone the best care we can.
Oh, Dr. Fontana, I can't thank you enough for all you do. You certainly are a credit to neurosurgeons and to our hospital, and I thank you for being here, and for doing the things that you do. So everyone, this morning, good morning. Dr. Victor Politi. I'm the president and CEO of the Nassau University Medical Center over on Hempstead Turnpike, and I really want to thank you all for listening this morning here on Saturday, and I hope you guys took something away from today's half-hour talk with Dr. Fontana, and enjoy the rest of your day today, and stay healthy and be healthy. And remember, lift with your knees. Okay, thank you. Goodbye.